Hello, I'm Dr. Evan Adelstein. I'm one of the electrophysiologists here at Albany Medical Center. I'm going to be talking about our cardiac electrophysiology program and how it relates to the fellowship. There are currently two attending electrophysiologists, myself and Dr. Loca. We also have a PA, Adam Schwartz, and three nurses who help to check our device patients. So why would you like to come to Albany Medical Center to consider EP? Well, first and foremost, EP is a part of cardiology, despite what some cardiologists think. And sometimes we can actually cure people, which is always a nice add-on. For example, this is a fluoroscopy image of a patient undergoing an ablation for WPW. And on the right, we see electrograms, and there's pre-excitation on the top where the surface is. And after the application of radiofrequency energy at the tip of this catheter, you can see that the delta wave in this lead goes away instantaneously. And that patient is cured from something that he or she was born with. So that's pretty exciting to be able to do that just with a single catheter. In terms of the fellowship and EP, we have a robust consult service where you'll be involved in clinical decision making regarding patients with arrhythmias. We're involved with device management in terms of routine device interrogations of pacemakers and defibrillators, troubleshooting, reprogramming, and gaining familiarity with devices since they are increasingly a part of clinical cardiology, and arrhythmia diagnosis and management in all settings, including inpatient and outpatient. And again, I stress that EP is a part of cardiology, and that's the primary focus for our fellows. Fellows also have an opportunity to read Holter and loop monitors, pre-read them before they're read by the attending, and participate in EP clinic in terms of the outpatient management of patients with arrhythmias and devices, and also come into the EP lab to gain some familiarity with the procedures we perform so that the EP lab isn't a black box where patients disappear and come out magically cured. EP procedures are performed every day at Albany Medical Center. We perform a variety of procedures, including AFib ablations, mostly pulmonary vein isolation, but also additional ablation for atrial fibrillation. PVC ablations, largely idiopathic, but also ventricular tachycardia, that's both idiopathic and ischemic. SVT ablations, including typical and atypical AV-NRT, Wolff-Parkinson-White, atrial tachycardia, and atrial flutter. We implant defibrillators, including biventricular defibrillators, pacemakers, including biventricular pacemakers. We implant quite a few implantable loop recorders, which the fellows largely do by themselves once they are able to do so. We also perform laser and mechanical lead extractions for both infections and lead management. Left atrial appendage occlusion devices, which at this point is the Watchman device. This is largely right now done by our interventional colleagues, but that's always a moving target. And the micro leadless pacemaker implant. We follow about 2,500 implantable devices, including pacemakers and defibrillators, in our outpatient clinic, and over 500 implantable loop recorders. There are about 250 remote transmissions per week for all of the above, and about 50 inpatient in-clinic device checks per week. And fellows can always go into the device clinic and learn how to do interrogations to get some more familiarity with that. We have 3 fully equipped EP labs. One was just renovated. In fact, it was finished this week. We have 3D mapping in all 3 rooms, including the Cardo system, the EnSight system, and Rhythmia. We have intracardiac echocardiography in all 3 rooms. And I'd say atrial fibrillation ablations account for about a half of all of our ablation volume. Here's an example of a map generated during an atrial flutter ablation. This shows typical counterclockwise flutter going around the tricuspid annulus. And there it is, it just finished. So it's going from the ablation line around the tricuspid annulus in a counterclockwise fashion. That's one of the cool maps that we can generate. Intracardiac echo, we used the phased array system. This shows the transeptal needle tenting the fossa ovalis prior to transeptal puncture. This shows an ablation catheter in the aortic root going into one of the aortic cusps. We'll typically have a view like that when we're ablating PVCs that are coming from the left ventricular outflow tract. This is the short axis view of the same with the catheter in the base of the left coronary cusp, the left main coronary artery visible there. We ablate both paroxysmal and persistent AFib. We do ablate quite a bit of persistent AFib. These patients tend to be more challenging. In addition to the standard pulmonary vein isolation, this patient here had both a roof line and a floor line, as we call it, to box off the posterior wall, which is this area. And after the ablation is performed, all of the area in this box and also the veins are red, and red is dead in our system. So hopefully this patient had a good clinical result. We perform ventricular tachycardia ablations. This is a patient with ischemic ventricular tachycardia. This is a voltage map that we generate in sinus rhythm. And the red areas are areas of scar, and the other colors except for purple are areas in the border zone. And the red here are the ablation lesions. This is the ventricular tachycardia, which actually terminates just at the end with one application here of radiofrequency energy. We always like to see Wolff-Parkinson-White patients because that is, again, something we can cure quite easily. This is a patient with a posterior septal bypass tract. Here we're mapping earliest atrial activation while pacing the ventricle, and the red area, which is kind of obscured because of the ablation cloud, here in two separate views, is where the ablation was performed to get rid of this accessory pathway. We also do cryoballoon procedures for AFib, especially for paroxysmal AFib. This is an example of a patient who actually had, this is a loop recorder where the black areas are the amount of AFib he was having, and it got more and more till he became persistent. And on the day of his ablation right here, he's had no more AFib. I can tell you he's actually done well for the next year at least. The cryoballoon is a balloon that we inflate in the pulmonary vein ostium and occlude it. When we inject IV dye, it hangs up like this, and then we freeze the entire pulmonary vein in one shot to eliminate electrical conduction in and out of the vein. We also have atypical atrial flutter ablations that we see from time to time. This is a patient who actually had a right atrial flutter, probably after surgery, where the flutter circuit goes in a clockwise direction around this central area, which on voltage mapping has an area of low voltage. This is probably where the atriotomy scar is from a prior surgery. And then, of course, we do device implants. This is a patient getting a biventricular pacemaker. They also seem to have a mitral annuloplasty and an aortic valve replacement. We have an active research program here, largely clinical research. My personal interests are biventricular pacing, and we're also looking at patients with implantable loop recorders as well as pacemaker leads, looking at electrical abnormalities. There's also an interest in cardiac sarcoid. And we have some industry-sponsored research being performed. The Untouched trial looking at subcutaneous defibrillators, sponsored by Boston Scientific. The Preempt heart failure trial, also sponsored by Boston Scientific, looking at heart failure monitoring in patients with defibrillators. The Short Point study with Biosense Webster, looking at patients with paroxysmal atrial fibrillation. And again, I mentioned before some of our current physician-initiated projects, and fellows are encouraged to become involved and hopefully get some abstracts and publications. We had one abstract at Heart Rhythm Society this year. Unfortunately, it was canceled, but it was still published. I appreciate your time, and if you have any questions, please don't hesitate to call me. That's my email. And hope to see your application, and good luck.